Good afternoon, everyone, and good morning to our friends on the West Coast. Welcome to this online Capitol Hill briefing, the stakes for primary care, impact of COVID-19 on primary care access, and the urgent need for action. This briefing is being co-hosted by the Pacific Business Group on Health. I'm Sean Grimminger, Director of Policy for PBGH. Also co-hosted by the American Academy of Family Physicians, and the Partnership to Empower Physician-Led Care. I'm going to very quickly walk through our agenda, and then I'm going to introduce you to a couple of members of Congress who have gratefully joined us for today's briefing. So again, my name is Sean Grimminger. We're going to first go through and after hearing from the co-chairs of the Congressional Primary Care Caucus, we will hear from my colleague, Elizabeth Mitchell, President and CEO of the Pacific Business Group on Health, about why this issue is so critical to our nation's families. Then we're going to hear the experience of frontline providers, both from experts and also some actual frontline providers who are providing care every day to people in their communities, both those who have COVID-19 and everyone else. We're going to hear from patients advocate and from Elizabeth again regarding the impact on employers. And then we will close out with legislative recommendations from our good friend Sean Martin with AAFP before we finally go to questions and answers. Folks are able to ask questions in the chat box on your screen. You will actually be muted throughout the conversation, but you can put in your questions in the chat box, and the questions will be held until the end of the presentation when my colleague Erica Kiske at AAFP will help go through the questions. So without further ado, I'd like to turn the call over to Congressman Joe Courtney, Democrat of Connecticut and co-chair of the Primary Care Caucus. Mr. Courtney.
Great. Thank you, Sean, for organizing this, and to your partners as well. And, also want to say hello to my colleague, David Rouser from North Carolina, who's co-chair bipartisan caucus on primary care. Just want to say that your timing in terms of organizing this event is very on target. There's been 4 COVID-related pieces of legislation that have had some pretty large emergency appropriations for healthcare providers. Coming from Connecticut, which is about 5th in the country in terms of the COVID outbreak, and I know North Carolina is also feeling the brunt of it as well. The primary focus, a lot of the funding and certainly discussion has been, for appropriately so, in terms of hospital-based healthcare. But as hopefully we sort of move past the peak hospitalization, and that's actually happened in Connecticut over the last 5 or 6 days. The number of hospitalized cases is starting to trend downward. I think we have to pivot to the next sort of challenge, and certainly what we're hearing in Connecticut is that the type of patients that primary care doctors deal with day in and day out, those with high blood pressure, diabetes, those chronic conditions that really require constant maintenance and attention, which is really, in many respects, the wheelhouse of primary care network in our healthcare system, is really going to, if anything, intensify. And the need to make sure that if there's a COVID-5 bill, which I personally think there is, or other follow-on legislation, that the Congress be really very aware of the fact that investing in helping this network, which has been very stressed, like any small business in many cases, as well as obviously the downturn in appointment and visits, which is temporary. We all know that, that we really have to make sure Congress is smart about trying to pivot both public policy and budget policy to really buttress that critical end of the healthcare system. So again, the Primary Care Caucus is on standby in terms of helping you broadcast those recommendations, which I know you're going to discuss later this morning. And again, it gives me great pleasure to yield to my Republican colleague from North Carolina, who, again, his office has been just great in terms of working with the different caucus visits in Washington, as well as the briefings for a much wider group of staff on Capitol Hill. So David, I yield the floor to you, and it's good to see you through Zoom, and hope you're staying safe.
Thank you, Joe. I appreciate the introduction, and I identify myself with all your comments. It's great to have such a perfect partner and a gentleman named Joe Courtney. So anyhow, I hope you're doing well and staying safe too. I want to thank everybody for being on the call, and particularly the organizers who have put this together. Primary care is critical to the healthcare of the nation. It's why Joe and I agreed to found this caucus, and it's just as critical and really more critical now in the wake of the COVID outbreak. I talked to a lot of different doctors all throughout my district, all throughout the state, and elsewhere as well. And I'll be candid and say I had not, when this hit, I had not thought about the business aspect on the healthcare community that so many private practices are facing. You think about your Main Street businesses, you think about the agriculture sector and the supply chain disruptions there, and you think about the restaurants and all the employees being laid off. But I'll have to say, probably in the first day of this, my first 5 calls were from doctors who saw the writing on the wall in terms of the loss of revenue for their practices, particularly when you can't do elective surgeries. And then, of course, you have a whole group of individuals out there that have regular healthcare needs that have postponed even talking to anybody about their needs, or regularly scheduled visits, then other issues that come up from a health-related standpoint that aren't even being addressed at the moment. And of course, that's going to create even more demand on the healthcare sector as those illnesses and issues grow in their severity without care here in the meantime. So greatly appreciate everything that you all are doing on the front lines. You're incredibly important to the healthcare fabric of the country, but not only that, the economy as a whole. Healthcare is a huge portion of the economic output, as we all know. I do want to commend the administration for their pretty aggressive efforts in expanding coverage for telehealth services through Medicare, and also in dealing with COVID. I think that certainly is a benefit to the rural areas that Joe and I represent, and as well as elsewhere in the country. And I think that really is one of the key avenues of care as we move forward. The opportunity to be able to do this online to the extent practical and possible is going to help a lot of people, because who knows when we're going to round the corner. I'd love to think that a therapeutic cure is right around the corner, but we'll just have to wait and see. I know there's some promising developments on that front, and that'd be the best news any of us have heard if something turns out to be the absolute perfect antidote to this. But in the meantime, look forward to getting your suggestions and recommendations of things that we can incorporate in any future package moving forward. And like I said at the outset, appreciate the opportunity to work with Joe and each of you as we advocate for this very important cause, and that's to encourage and do everything we can to promote primary care in this country. With that, I'll yield back.
Thank you very much, Congressman and Congressman Courtney. Appreciate you both spending a little bit of time with us this morning. Feel free to stay on as long as you like, but I understand you may need to run. And again, thank you for your leadership and support for primary care. At this point, I'd like to turn the call over to my colleague and boss and friend, Elizabeth Mitchell from the Pacific Business Group on Health, who's going to talk about why this issue is absolutely so critical to so many people around the country. Elizabeth?
Thank you, Sean, and thank you everyone for being here. In particular, thanks to Congressman Courtney and Congressman Rouser for really elevating this critical issue, and clearly to our partners, AAFP and PEPC. We need to all come together to really address this crisis that is emerging in primary care. The Pacific Business Group on Health is an organization of jumbo employers in the country, manufacturers, retail, high tech, and collectively our members spend $100 billion a year on healthcare to keep their employees and their families healthy. They purchase care on behalf of 15 million Americans. And they know that to get value for that spend, primary care is essential. One of the CEOs of our large companies asked recently, for all the money we're spending, are we buying health? And frankly, the answer is too often no. So the future of employer-sponsored insurance in this country really depends on a high-value healthcare system. And we strongly believe that primary care is the foundation of that system. Next slide. Unfortunately, the US is not getting a high value for our healthcare spend. We spend about twice as much, and frankly, the outcomes are really not acceptable. We are over-reliant on specialty care. We just don't have the outcomes we should expect for what we are investing. And we are really seeing the challenging impacts by COVID-19 of what happens when you really don't structure the healthcare system effectively. We are committed to primary care because we know it does lead to higher value. If you go to the next slide. And we have actually demonstrated this. In addition to having an employer membership, we also work directly with practices in California. And over the last few years, through a federal grant, we worked directly with small practices. And those that we supported to actually transform and be robust primary care centers, we saw that we avoided over 67,000 unnecessary emergency room visits, over 59,000 avoided hospital admissions for care that could be treated in a primary care setting. We believe this is scalable. This is something that can be done around the country if we properly invest in and support primary care. This is of great importance to our employer members. They are asking their commercial health plans to ensure that they are paying effectively for this care, because in the end, that is what is going to keep their employees healthy and productive. So we are so grateful for the primary care physicians who you're going to hear from today. They are on the front lines of making this work, but wanted to put it in context because we have seen that our physical health is intimately linked with our economic health in the country. We will not reopen the country until we can ensure that people are healthy, and we believe that primary care is the answer to that. But right now, because of our payment system, we are at risk of losing up to 50% of primary care practices in this country because we aren't paying effectively. So we are very grateful again for our panelists and our partners and for your attention, because this is of critical importance, not just to our employees, but to the entire healthcare system in the United States. So thank you very much, and I will turn it back over to Sean.
Thank you very much, Elizabeth. And now it's my pleasure to turn the call over to a panel of experts and frontline physicians. First, we're going to be hearing from Dr. Rebecca Etz, who's the co-director of the Larry A. Green Center at VCU. Dr. Etz is going to talk about some of the findings from surveys that she and her colleagues have produced, demonstrating the impact of COVID-19 on primary care practices. And then she'll be running a short panel with three frontline clinicians who are really working hard right now in the middle of the pandemic to provide primary care to their patients. Tabitha Childers, who is an APRN in Little Rock, Arkansas, Dr. Beverly Jordan from Enterprise, Alabama, and Dr. Guy Culpepper, who runs a primary care practice in the greater Dallas area. So with that, I'm going to turn over to Dr. Etz.
Thank you. Next slide. I know this is a conversation for most of you that's just in a long line of other meetings today, but I'm gonna tell you seriously, we need to talk. I'm gonna ask you to hit the pause button on your life and just put your other work aside and focus. We need your full attention because primary care is dying. The US has systematically starved it for more than 30 years, and the American public deserves better. The data informing this presentation were collected 2 days ago. It's a stark view of what primary care looks like on the ground. and one that you still have a chance to fix. I only have time for highlights, but I'm happy to follow up with any questions later. My comments are my own. I represent no particular specialty or organization. These data were collected across all primary care specialties and clinician types. Next slide. For most people, primary care is the first point of contact with the healthcare system. It is literally the front line. It is a relationship with a person and a team who take into consideration your full social and medical history when participating in your care. Primary care is over half of all medical visits across the US. That's 500 million patient visits. It does this with 1/3 of the healthcare workforce and less than 7% of the national health budget. And that bar at the bottom is not a typo. Primary care receives 0.2% of NIH funding. This financial picture is an epic fail. Next. On March 13th, the Green Center, in conjunction with the Primary Care Collaborative, launched a weekly survey of primary care clinicians. It is the first and only of its kind. We are 7 weeks in and close to 10,000 responses have been collected. This survey is distributed with the help of over 50 national partners and organizations all across primary care. This is no time for us to fight among the professional guilds. This isn't a disciplinary crisis, it's a humanitarian one. All of these first responders are battling the first line of a health crisis like none that we've ever seen. Next. Primary care has a new normal. It's corrosive, debilitating, and constant. 3/4 of clinicians work under continuous and severe stress. Regardless of governance or structure, primary care is still the first on the scene and the last to receive support. They have limited testing capacity, not nearly enough personal protective equipment, but show up every day to help their patients fight a virus with no vaccine and no treatment. Next. When the pandemic hit, primary care moved swiftly and with clarity of purpose. Overnight, they adopted virtual care systems to prevent unnecessary coronavirus exposure and to expand avenues of access that serve the public. Despite the anticipated financial hit, clinicians adjusted to caring for patients at a distance. Despite significant decreases in patient volumes, clinicians continue to work harder and longer and at great personal risk. And yet 7 weeks in, over 2/3 report the majority of their work is not covered by any payment. Almost 50% have had to furlough or lay off staff. Next. 11% of primary care clinicians say they will close in the next 4 weeks, and 2/3 are uncertain about their sustainability 4 weeks out. Now, I want you to just think about that a minute. 11% of an industry will be shuttered, and over 60% of that industry struggles to picture their future 1 month ahead. There's not going to be an easy fix when this happens. Fewer than 20% of medical graduates are entering primary care. Our failure to figure out how to hold up this critical resource means that the largest public health crisis of our lifetimes could be an extinction-level event for primary care. Next. What about virtual care? Care delivered through video, secure messaging, and phone has exponentially expanded in the past 7 weeks. It is necessary. It is good, but it is not sufficient. Payment for virtual health is not yet at parity. Among those payers who have expanded payment, the new coding requirements are dizzy and cumbersome. Virtual health offered is not the same as virtual health received. Broadband access is currently not sufficient to support the country's needs. Many patients struggle with technical literacy and internet access. Over 2/3 of clinicians report patient obstacles to virtual health. And this modality of care cannot replace the need for tests, vaccines, procedures, or simple human touch. Next. In the immediate and necessary response to COVID, Many usual activities have been pushed aside. 80% of clinicians report limited well and chronic care visits. Delayed usual care and avoidance of medical settings is starting to cause great harm among segments of the population. Clinicians express grave concerns about chronic conditions that continue unchecked and cancer screenings or vaccinations that pass unaddressed. Next, we are bearing witness to a new tenuous and fragile contract. The contract goes something like this. As your primary care clinician, I will be there for you when and where you need me. I will be worthy of your trust. I will treat you with the wholeness of dignity and personhood. I will put your interests above my own. In exchange, we as a society agreed to invest in this highly effective personal good. COVID-19 has caused a final blow to this social contract that has been eroding through decades of neglect. Quality measures are misaligned, documentation is burdensome, and for too long, we have enacted piecemeal payment and delivery solutions. I actually find it fascinating that many of these challenges have been completely set aside during the pandemic. To get done what needs to get done, primary care blew off those obstacles and accelerated the pace of change at their own peril. The next action lies with you. The opportunity to restore this social contract is now, but the window is urgent and immediate. With that, I am privileged to introduce a few of the frontline heroes of primary care. They are certainly worthy of our trust and gratitude. I'd like to start by turning the floor over to Tabitha Childers.
Thank you, Dr. Etz. My name is Tabitha Childers, and I'm the practice administrator for Autumn Road Family Practice. Autumn Road Family Practice has been serving the people of Central Arkansas for over 70 years, and we represent 15,000 covered lives, many of which are the grandchildren of our original patients. During this time, our practice has managed to remain independent, financially viable, and adaptive to the healthcare needs of the community. On Thursday, March 4th, we had our monthly owners meeting. We discussed COVID-19, gathering PPE, but it was business as usual. Never did we imagine that we would walk in Monday, March 9th and only see 45 patients on our books. Monday is typically our busiest day, and we see an average of 120 patients a day. As members of the Aledade ACO, we participate in value-based care for our patients. Our leaders at Aledade have helped independent practices such as ours navigate the many financial options available, provided much-needed relief in the form of PPE, and helped us to rapidly implement telemedicine in order to bolster our revenue and safely serve our patients. We are doing our best to utilize telemedicine to provide transitional care management for our patients who have been hospitalized, manage acute and chronic conditions, screen for COVID-19, and provide population health and care management for our Medicare population, which is about 35% of our patient mix. Many of our older patients don't have the technology to complete these virtual visits. They don't have smartphones, tablets, computers, and being a rural state, internet capability can be an issue, although not as much for one as it is for one of our counterparts today. We are extremely thankful for the ability to receive the accelerated payments from Medicare, some stimulus funds, and a loan from the SBA, but our practice has already lost $150,000 in collective payments in March and April. Our stimulus funds were not enough to close the gap for even one of these months. We want to keep our doors open. We are committed to our patients and our community, but with overhead costs of greater than $300,000 per month and losses of $70,000 to $80,000 per month, we will not be sustainable for long. And loans are only increasing the size of the hole that we are trying to crawl out of. Our providers are making 15 to 20 calls a day in addition to their telemedicine visits in order to keep their patients healthy, check on them, and keep them at home. Please help us to continue this mission. We don't want to see 15,000 Arkansans go without much needed health care. Thank you so much for your time and for allowing me to speak today.
Dr. Jordan?
Hi, I'm Beverly Jordan. I'm a family medicine physician in Enterprise, Alabama. And as Tabitha said, yes, we have significant problems with internet and video access in rural Alabama, as you can see by what my picture looks like on today's screen. So I really do appreciate the opportunity to speak with you today. I am a senior partner in a rural private practice. We have 5 physicians, and our practice has been in existence for about 30 years. In addition to being a physician, I'm a business owner, a mother, a spouse to someone else who owns and runs their own business, and a member of our community, which I think has been a really important factor in keeping our practice alive during this crisis. You know, this has been bad. It's not been easy. It's been really, really hard. And as physicians, we are trained to never admit that anything is difficult. But this has been the most difficult challenge I have ever faced in medicine. And I have stood on the sidelines and worked as a team physician at national championship games. And I would much rather yell at SEC coaches than have to deal with a crisis like this. You know, it's been hard from a stress standpoint, but it's also hard financially. So I employ 55 other people who work in a variety of forms in my practice. And we've made a lot of sacrifices to be able to continue to employ those 55 people. And in return, they've been really generous to us. We have a major limitation in our access to PPE. So my nurse goes home at night, and after she homeschools her child with ADD, which is not easy, she then sews homemade masks so that we have masks to wear inside of our practice so that we can stay well and take care of our patients. My chronic care managers have reached out to our suddenly huge homebound population and have taken all the goodwill from our community, the churches and the civic organizations that want to help take care of our practice, and channeled that into food drives and donations that we use our home health agencies to help us deliver to our rural patients who now have been stuck at home. You know, we all live mostly in places where when I want to go to the grocery store, I can swing by and stop. But that's not the way it is in rural Alabama. I grew up on a farm. We went into town to go to the grocery store once a month. You know, my parents still live on that farm, and it's not very far away from where I practice. We don't go to the store every day. So when there are shortages, you don't get to come back tomorrow and pick up what you missed. You just do without. And lots of our community members are doing without. So I really do feel like primary care and family medicine was truly made for a time like this. We work on the fly, we think, we move ahead, we make changes. Family doctors are not scared to make a decision and just kind of go with it and see what happens. And that's really been important in this, has been the ability to make a change and change when the change didn't work to a different change. But financially, we are very much putting ourselves at risk and depending on the goodwill of our patients and of the government to come back and take care of us after this is over. But it's been almost 2 months, and I'm not sure how much longer we can sustain this type of financial crisis. So we have received the PPP loan. We have received our Medicare advance payment. And that's what's kept us open for 2 months. But the monies we've received won't keep us open for 2 more months. And I'm afraid that this crisis is not going to turn in under 2 months. I'm afraid we have a lot longer time to deal with this. And we in family medicine really are the front lines. So it's kind of easy to close your eyes and imagine that the emergency room or the ambulance service is the front line, and they are, but they're not the only front line. 90% of people are seeking care in a physician's office because they're terrified to go to an emergency room, because their copay is higher in an emergency room, and because it's inappropriate to seek care in an emergency room. And we as primary care physicians with offices have been the forgotten front lines. We're here, we're taking care of our patients without access to protective equipment because it's all been sent to the hospitals. But we're doing the very best we can. The hospitals have gotten additional funding that we have not gotten as physicians, and we all need funding. Hospitals need funding, but so do physicians, because we need to be able to keep our practices open. If primary care practices in this country begin to close down at the rates that my coworkers are discussing, our emergency rooms will be overwhelmed because there are no physicians, not because we have a coronavirus crisis. And that is going to affect everybody, not just the 3% of the population that's going to die from coronavirus. One of the biggest effects that we've seen in our practice is that we had 3 new physicians that we have hired to join our practice in the fall that graduate this summer from their family medicine residencies. We are currently in renegotiation with their contracts and contemplating canceling those contracts because we cannot afford to support 3 new doctors for a year while they build their practice. That is unimaginable to me. That has never been a problem ever in my practice life. We are in a rural, underserved physician shortage area, but we don't have enough money to pay doctors to come into our practice. 6 months ago, that was a different story. This crisis has devastated our financial stability. And the thought that we have promised 3 bright, young new physicians who I anticipated being my partners, my coworkers, and people who work side by side with me in my community, and those hopefully that would be there to take care of me when I decided to retire and needed a physician, that we can't bring those people into our practice is devastating to me. We really need financial help to be able to support these types of activities in our practice. So I really appreciate your attention. There are lots of challenges with all of this, from access to testing, to access to PPE, to adequate video and audio and internet support for telehealth. You know, this is a huge crisis, and I appreciate your attention and desire to really help us out.
Dr. Culpepper?
Hi, I'm Guy Culpepper. I've been a family doctor for 32 years. I started solo and I've added 16 wonderful providers and 70 employees. On March 13th, I came into a very busy office and had every one of those 70 employees call every patient that we had scheduled for the next 2 months and reschedule them. Our job is prevention, and we knew that bringing in sick people into our office that mixed in with well people was not going to be a good combination. My staff was kind of worried about it, said we don't have any money. We can't do that if we're doing a turn them away. And I told them, don't worry about it. We're going to get help. The country needs us. We rescheduled hundreds of patients. We called thousands. We take care of 30,000 patients. I sent an email to all 30,000 of them that weekend and said, social isolation is the thing that's going to save us. You guys got to stay home, and we're going to call you. And my staff and I did. We called hundreds of people every day. It's what we did. We saw 2 people in the office. We'd make 200 phone calls, each of us. We made a difference. I hear Dr. Jordan talking about how we're the front lines. I reminded my staff that if we're going to flatten the curve, it starts with us, because as soon as they walk out of our office, they're part of the curve. The curve doesn't get flattened in a hospital. It gets flattened in a family practice office. And meanwhile, while you're trying to worry about COVID, you got a whole bunch of people that are worried about their diabetes, their blood pressure. So we're on the phone managing those. Probably 10% of those diseases could be paid for with telehealth. We made 200 phone calls. We could get paid for maybe 10 of them. 180 of them are the thing we call courtesy calls, what family doctors do. That unmeasured part of the economy where we call to check and see how you're doing. We kept thousands and thousands of people from the emergency room. In fact, we were the first practice in this area to do COVID testing. When the emergency room doctors and the emergency room nurses started getting sick, they came to our drive-through to get tested. We tested 300 patients. We had 50 of them positive. We had 15 in the ICU, and I lost a really good friend to this disease. This is real. It was devastating, but where it hurt us the most was financially, because after 2 months of no money, we found out we weren't going to get a PPP loan. We went through a big bank, the one we were used to, and they said, we're not going to get it. So I had to call 70 of my employees into the lounge in one setting and tell them, I'm sorry, I love you guys. You're working 20-hour days, but I'm going to have to furlough every one of you. I can't dare have you work and not be able to pay you. Every employee on my staff was furloughed. Every doctor here has been working for free for 2 months. We understand our commitment to the country. We're the first in line to do this. We were the last in line for a loan. We haven't stopped doing it. My doctors are here volunteering. They're out in the hall right now calling people and helping. I'm paying my staff minimum wage. I had the patients get together and do a GoFundMe because it's the only way I could keep my doors open. To this point, I haven't gotten $1 of government assistance, not one Medicare dollar, not $1 from any agency. We're doing this out of love. And when you lose us, you got 30,000 people out there that got no place to go. So let's be clear about what we're losing when you lose a practice like ours.
Thank you. I appreciate it. Thank you for each of your comments. As our time grows shorter, I'm going to ask a quick question of each of you. If you could keep your comments short so that we can entertain questions from others in the audience. First, I'd really like to talk to Tabitha. You've spoken briefly before about the rapidity with which this crisis hit your practice. I wonder if you might return to it.
Sure. Like I said, we walked in March 9th and our patients, we had 45 patients on the books. By Friday, March 13th, we had to furlough 12 employees that had been here, some of them for years, 10 to 15 years. It was a heartbreaking day. We rapidly implemented telemedicine that week. Within a matter of just a few hours, we had telemedicine up and running, and we had to shorten our hours that our doors were open. We allow patients in our office for just a couple of hours a day. But it was that quick that we realized we were not going to be able to sustain our overhead and keep everyone working. So we had to make the really tough decision to let 12 coworkers go and furlough them so that we could keep our doors open and, like I said, serve the 15,000 lives that we cover. And it was just not an option. We had to do it fast.
I appreciate that, Tabitha. And Dr. Jordan, if you don't mind, you mentioned the fuzziness of your picture. Can you tell us a little bit why that is and what it means for your care delivery in your setting?
So my picture is fuzzy for two reasons. In rural Alabama, we have exceedingly slow internet. My internet's actually been down once already today. But in addition, when we made the rapid transition to telehealth, we had to use the audiovisual equipment that we had currently in our office, and we had never done telehealth visits before. So we tried, when we realized how poor our images were, we tried to purchase new equipment, but there was nothing available on the market that we could afford. And at a time when we're not making any money, I'm having to make huge investments in infrastructure, in telehealth, as well as in personal protective equipment. So I had to make the choice to buy things to protect my employees and my patients instead of upgrading my equipment so that my 15-year-old camera on my computer was a little bit better. So, it's difficult, but it's also difficult for my patients because they don't have access to devices to use telehealth or to adequate internet service. Many times when their child has gone to the home of my patient to set up a telehealth visit, even then the internet is so slow that after 30 minutes of trying to connect and talk, they'll end up hanging up and picking up the phone and calling for a telephone visit. And those visits are not well paid for at all, somewhere along the lines of $1 per minute. So certainly very poor payment for the work that we're doing. And my staff has actually spent an extraordinary amount of time making videos, teaching my elderly, poor, and rural patients how to use our online services so that when they can get into the services, they're able to use those things to try to cut down on the time that their family members are having to spend doing that.
Dr. Jordan, thank you. Dr. Culpepper, I've admired previously how you've talked about your value-based model. I know that a value-based model requires a certain kind of payment system and lots of face time. Could you tell us a little bit what it's mean for your successful value-based model to operate during this crisis?
One of the greatest things we do is keep people out of the emergency room. What that means is that we have a full service clinic with x-rays, sonograms. We have a sports medicine doctor who sets bones right here. We do casting. We have over $200,000 worth of vaccines sitting in our refrigerator. To provide the kind of services that save the employers millions of dollars means we have to have an infrastructure here in place that can provide care that people don't have to go to an emergency room to get. So when you close down an operation like this, I've lost $500,000 in 2 months. Now, you got to keep in mind, as a family doctor, I only make about less than $100,000 a year at the corporate level. It'd take me 5 years of corporation just to make up what I've lost so far. And not like some of the other specialists, you know, family doctors, we make $200,000 a year. I've got everything in my life tied up in my business right now. All my retirement, all my savings, and all my heart. And what we've done is we've saved America millions of dollars. We've saved our businesses millions. We've saved insurance companies millions. And I'm sitting here dying, and not one insurance company has said, let me prepay you for a little bit of what we've already taken premiums for. And not one government official has said, hey, guy, you're saving this country with this COVID on the front lines. You're risking it. You're wearing those goggles from Lowe's, for God's sakes. Let me get you something to help you take care of people. Let me write you a little check. Nothing. Value-based, we've done it. We haven't had value back. And guess what, though? All that, I'm going to keep doing it. Because by God, I know what my mission is here. But when I'm gone, when I can't do it, you're going to miss me.
Thank you. I appreciate your time today. I want to turn the floor back over to Erica.
Actually, that's Sean here at PBGH. Thank you very much, Dr. Etz. Thank you, Dr. Culpepper, Dr. Jordan, Ms. Childers. I tremendously appreciate all of the work that you're doing, and thank you for spending a couple of minutes with us. To wrap up this section, talking about the experience of frontline providers, I'd like to turn the call over to Dr. Jack Westfall with the Graham Center at the AAFP, who's going to provide a little bit more context before we move on to the next sections in our presentation. Dr. Westfall.
Next slide, please. Thank you for the opportunity to share data from the Robert Graham Center for Policy Studies in Primary Care and Health Landscape. The need for ambulatory primary care has increased over the past month. Patients with COVID-19 symptoms, illness, and questions are flooding primary care practices, as you have heard. Another illness is not sheltering in place. Acute and chronic disease did not go on holiday. While there is urgency at the hospital acute care setting, the vast majority of COVID-like illness is seen out in the community in primary care setting. Last week, just 4.5% of emergency department visits reported to the CDC National Surveillance Program were due to COVID-like illness. Most patients with a respiratory illness receive care in the primary care setting. For instance, as seen in this slide, in a given year, 19.5 million patients are seen in primary care for an upper respiratory illness, and a URI is part of 64 million primary care visits. 10.5 million patients are seen for bronchitis, and each year, primary care physicians care for 9 million patients with pneumonia. In contrast, just 900,000 patients are hospitalized due to pneumonia. While trying to balance in-person and virtual patient care, the payment for telehealth has been inadequate and often just missing. The primary care practice that has relied on fee-for-service payment, this shift for primary care practices that have relied on fee-for-service payment, this shift has been devastating. Next slide. In early March 2020, there were 138,000 physicians whose practices supported 1.8 million jobs, including those of the physicians, for a total of $154 billion in wages and salaries. Based on lost revenue from patient visits over the next 3 months, upwards of 60,000 family physicians may cut back or stop practicing. The loss of primary care physicians is compounded by the resulting loss of 784,000 medical assistants, nurses, and other staff, and lost wages and salaries of $64 billion. In March of this year, 750 counties in the United States had a family physician shortage. Next slide. Without significant policy changes, this may soar to 1,800 counties with a family physician shortage, as seen in the second slide. And the impact has been immediate. By late March, the U.S. Bureau of Labor Statistics reported 43,000 lost jobs in healthcare, chiefly in ambulatory care, including 12,000 in physician offices. Thank you for the opportunity to share these findings with you.
Thank you very much, Dr. Westphal, and I appreciate the additional context you provided. As hopefully all the attendees can see, the impacts here are enormous, and the downstream impacts could be incredibly significant. It's now my pleasure and honor to turn the call over to a colleague, a friend who I worked with for several years when we were both at Families USA. She and I are both new to our positions. Cincy Hernandez Cancio is the Vice President for Health Justice at the National Partnership for Women and Families. And Cincy's going to talk to us a bit about the impact on patients, and particularly folks who are low income and underserved, who we know have experienced the brunt of COVID-19 and would experience the brunt of the collapse of the primary care system if we allow it to go that direction. Cincy? Cincy, I think you're on mute. There you go.
Can you hear me now?
You're good.
Okay, I'm sorry. I've been having multiple technical difficulties. I think that's one of the things that we're all dealing with here in the shelter in place culture that we're in right now. I am the Vice President for Health Justice at the National Partnership for Women and Families, which is a nonprofit, nonpartisan healthcare organization that's focused on improving the lives of women and families across the country. I'm also here as the proud daughter of a primary care physician. My dad, Dr. Martin Hernandez Bem, was not just a family physician all his life. He was also the co-founder of the family medicine department at the Ponce School of Medicine in Puerto Rico. So I've always understood, just from being in his office and understanding, helping him grade his exams, et cetera, like how important it is to have primary care physicians that are looking at the health of like a whole family. That said, it's very clear that from a policy perspective, if we are to save the future of the healthcare system, especially in a way, given the escalating costs of healthcare, the healthcare system of tomorrow must be built on primary care. And what we have right now is a terribly unbalanced healthcare system that is, rather than building on a strong foundation of primary care, is basically starving what has to be the foundation. I am so glad that I'm following a previous presenter that was showing the map of where currently primary care shortages are. And how they're expected to expand. And I think that, you know, if you were to overlay that map, you would see that the majority of these shortage areas are occurring either in rural communities or in communities of color, and these are communities that are already facing deep inequities in other areas. So it's a 1-2 punch. It's not only the fact that they don't have anywhere to go to take care of their health, they're also in places where there are other social factors that are undermining their health. So they're the ones that actually need the most investment in ensuring that their health is protected, in preventive care, in chronic care management. Because the other thing that we know is that they're also in places where there are, you know, hospital closures and consolidations that are also limiting access. But at the end of the day, you need to have that family physician, that primary care internist, that pediatrician that the family trust, that the family can communicate with, that understands the community that they're coming from, that understands the multiple barriers that they may be facing, economic, financial, social, otherwise, in being able to manage their health. And we cannot get to a place at the end of whatever ends up being the new normal after this pandemic, where things for these communities and these families are actually much, much worse than they were coming in. So we need to make sure that whatever policy solutions are developed and advanced, they center on protecting the access and the quality of care in the areas where this is already threatened, even before the pandemic started.
Thank you very much, Cincy, and I appreciate you taking a couple of minutes with us. At this point, I'm going to turn the call back over to my colleague, Elizabeth Mitchell, who's going to talk about what employers are doing and the downstream impact on payers and employers. Elizabeth?
Thank you, Sean. And there is honestly nothing I can add that would be more compelling than what we just heard from the practices. And I just want to offer my sincere gratitude personally for what you are doing, and apologies for the system in which you are trying to do it. We will have very specific asks. My colleague and friend Sean Martin from AAFP will be following with specific legislative asks, but there's a couple of things that I would like to add. We are very grateful for the work that Congress has done to make sure that there has been money going to the hospitals. They need that funding. We are grateful that they are getting that funding, and for those providers on the front line. However, you cannot assume that that money is actually also going to primary care practices. We reached out on behalf of our employers to health plans to ask if they were supporting primary care practices. And I literally just got an email back this morning from one of the largest health insurers in the country saying they don't think they need to because practices are getting everything they need from the government. We know that that is not true. I plan to send that person this recording. We need actual clarity from Congress that some of this money needs to be prioritized and directed to primary care. We are going to talk further about that. But I also want to step back, and if you go to the next slide, really reinforce that even though the coronavirus has exposed the pre-existing failures of our payment system of fee-for-service, we think we have got to take the step now, even in the midst of this challenge, to change payment so that we support population-based care, that we are not reliant on fee-for-service. And in a recent survey of our membership, 90% of our members also agree that this was very important, and 100% collectively think we need to act now. So we can bring the private sector purchasers to the table for a multi-payer initiative. We truly must act now, or as you heard, we will be losing the primary care base that we all need. I also want to say I was co-chair of PTAC, which designed alternative payment models, or rather approved them for CMS. We know that the models exist. They are out there. We cannot get any of the large payers, public or private, to implement them. That is what we need to really push on now. Next slide, please. So what are we doing? We're doing our part to the extent that we can. We are looking to pay for telehealth and insisting that commercial carriers also reimburse for telehealth. We are directing our plans to the extent that they are responsive to actually provide this immediate cash flow in advance, like CMS had done. We are absolutely advocating for new payment models that actually take practices off the fee-for-service treadmill, because we are seeing right now clearly that when you don't have people going into the practice for any reason, they're not getting paid. This is when we need them more than ever. We are working to help transform primary care. We have, as I mentioned, we have teams that work directly with practices, understanding their needs, helping them get the resources they need. We're coordinating requests and, again, advocating for these changes and working like we are today to inform policymakers. Next slide. What do we want? We want a strong, patient-centered primary care delivery system. This is the necessary foundation to get to the value in healthcare that employers are looking for. We don't need to spend more money in healthcare in the US. We need to allocate it more effectively to where it adds the most value, and we believe that is in primary care. And I also want to say we believe that that is an integrated behavioral health, which we think is part of primary care. A primary care system must deal with chronic disease management. They are best equipped to do that. And a system that rewards patient-centered care with teams. So we believe that this is all doable. We have to pay for it. Next slide. Finally, we believe that there is significant risk that if we do not support primary care practices, they will either close or get bought up by the healthcare systems that are out there. And we know from evidence that that increases prices, it drives market consolidation, and it does not improve quality. We need these practices to remain independent and robust in their communities. And we are trying to avoid this market consolidation that actually really harms the purchasers of care and doesn't give us the quality that we deserve. So we are asking for immediate intervention to avoid that eventuality. Next slide. Great. I will turn it over to my partner, Sean Martin, to really ask for what we know is needed immediately.
Elizabeth, thank you so much, and thank you all for joining us today. I would just like to take a moment to thank Elizabeth and the Pacific Business Group on Health and Kristen at the Partnership to Empower Physician-Led Care for co-hosting this with the American Academy of Family Physicians today. I too just would, Tabitha, like to extend my appreciation to Tabitha, Guy, and Beverly, not only for sharing their stories today, but for continuing to provide care to their communities in these difficult times. And I hope we can help them soon. So next slide. So there are some unified legislative asks that our organization would present to you today for your consideration, both in the short term and certainly in the next round of legislative efforts. I think the most important is to provide immediate financial assistance to ensure that these physician practices can offset their loss of revenue and continue to serve patients in their communities. You're well aware that there is a large amount of money that has been allocated to HHS for distribution across the healthcare system. We list 4 items here that would help those practices. I would draw your attention to the per beneficiary per month payment or some type of lump sum payment that would go out to help practices with their immediate cash flow challenges. This is the thing that you heard from the 3 clinicians today, is that they face very challenging cash flow issues now, and we need to push money out to help them continue operations. And then we would advocate for the allocation of some of the small business loans being set aside for physicians and physician practices and other healthcare entities. We think that this is a reasonable request. The information that Jack shared with you from the Robert Graham Center demonstrates that not only are they essential to the providing healthcare to 330+ million people in the country, but they also are small businesses that contribute to the economic viability of their communities and employ and contribute to the economic empowerment of millions of people across the country. Next slide. We also would ask that you consider the long-term sustainability of physician practices moving forward. And Elizabeth touched on this, the value-based payment programs or delivery or payment system reforms. Rebecca gave you a great overview of the historical failures of our delivery and payment models when it comes to primary care. Elizabeth pointed out the important role of the PTAC and the Centers for Medicare and Medicaid Innovation on advancing these new delivery and payment models that are better aligned to support primary care in an ongoing basis, not just in the midst of a pandemic. We would encourage Congress to direct the Secretary of HHS to expand the CMMI models that are already in existence, such as the Primary Care First program. This would provide a prospective payment and economic stability to primary care practices across the country. Next slide. Our third suggestion is that we promote telehealth coverage and reimbursement policies. Congress and the administration have taken tremendous steps to empower physicians to incorporate telehealth and virtual health platforms into their practice. They have eased regulatory requirements that make this more feasible, but it's time to align the payment policies across all payers, not just Medicare and some Medicaid programs, but it's important that we encourage all commercial health plans, including those self-funded ERISA plans, to align their payment policies so that telemedicine can be applied evenly across patient populations and health insurance programs. We also would ask that plans voluntarily choose to waive the cost sharing associated with telehealth, but they continue to pay the practices the full allowable amount for those telehealth visits. Next slide. And then our final recommendation is that we encourage benefit design that prioritizes primary care. So we've talked a lot about delivery system and payment reforms that empower the sustainability and scope of comprehensive primary care, but there also is a benefit design element. We need to incentivize individual access and engagement with the primary care system through our benefit structure. We have a number of recommendations here. I would draw your attention to allowing high deductible health plans to waive cost sharing, both co-pays and deductibles for primary care visits for the duration of the public health emergency. We think that's an appropriate request. And we would encourage, again, all health plans, including the ERISA plans, to cover at least one primary care visit without cost sharing throughout the public health emergencies. This is the time that we need people to engage with primary care, and we need to make sure that primary care practices are being appropriately compensated for their engagement with patient population. So next slide. I think I am, the one last thing, the consolidation, I apologize. As Elizabeth said, there's the detriments of consolidation within the healthcare system are well known. We know that it increases costs, it decreases access in certain markets. It certainly decreases access in rural communities and other underserved communities where consolidation takes place and the availability of physicians and other clinicians becomes more limited. So we would request that Congress direct HHS to require that all providers that receive funding attest to the fact that they would not seek consolidation or merger and acquisition activities for the period of 12 months. And we also think that HHS and the Federal Trade Commission should conduct analysis or surveys or studies to determine what happened as a result of the COVID pandemic in this time of instability in the primary care system, to see if we did see an uptick in consolidation and the impact on cost and access to care for individuals as a result of this crisis. So now I believe that's the end of my presentation, and I will turn it over to my colleague, Erica.
Hi there, thank you, and thank you to all of our speakers today. We want to go ahead and open this up to our participants to ask any questions of our panel, our clinicians and our experts. As a reminder, you can submit questions via the chat feature at the bottom of your screen. Go ahead and type questions into the chat, and we've got a few questions in here already. First question was, what can we do? What do you need? I think Sean Martin really laid out a case for what can be done from a legislative standpoint right away. Here's a question on telehealth that I would like to pose to Sean and Dr. Etz and anyone else who'd like to jump in. It says, the importance of virtual care during this crisis has been noted clearly. What are your thoughts on continuing to use this as a tool after the pandemic? Do you agree that payers need to adopt, support, and recognize this as a way to perform care? And how can we collectively advocate for that?
So Rebecca, if it's okay, I'll go first. I think telehealth, so my personal assessment on telehealth is we have jumped forward about a decade with respect to its adoption and kind of comfort level with that. I think the challenge we face now is right-sizing the utilization of telehealth and virtual health in the overall workflows of physicians and clinicians, and making sure that we're using it in the appropriate way that maximizes value both to the individual patient and also to the healthcare system. And I think that is highly achievable. I think we are viewing telehealth as kind of the 21st century house call, but that doesn't mean that it will take the place of in-person visits permanently. I think it will be a tool or a modality that's used by primary care to extend their engagement with their patient population through both convenience, but also through kind of a intervention or the house call mentality of meeting the patient where they are in their home to provide healthcare services. Rebecca?
Thanks, Sean. And I would add, for me, this is really simple. Primary care is meant to be there for you when and where you need it. And when and where you need it is sometimes in the office and sometimes at home. And payment structures and policies that place constraints on that ability just simply get in the way of us being able to take care of the American population. So telehealth as a term can be confusing. We actually started talking about it well before we were using the internet to do things like video visits. Virtual health is what we talk a lot about now because it involves virtual meetings where we can be synchronous, but it also involves secure messaging where we can talk back and forth asynchronously about a question. Virtual health can be very difficult if you don't have broadband, if you don't have data plans that can manage it, if you don't have easy access to data. But you know what? 96% of the US population, that includes people of all stripes and shapes, have a cell phone, and they can do phone visits. This is not hard. We could use those right now, and it requires no ramp up and no infrastructure. So yes, I think we should absolutely be supporting these things. We need to understand that they are useful and helpful and do not replace the need for a personal relationship with a trusted person in front of whom it is safe to be vulnerable and have the conversations you need to have about your health, your emotional, physical well-being. We can do that and also adopt the virtual care that expands our ability to meet the needs of the public.
Excellent. We have another question. I think this question I will send to Dr. Culpepper, and then Sean, if you have anything to add on. The question is about the provider relief funds that the Department of Health and Human Services has already started to distribute, and we talked about why is it that you feel that the existing relief funds aren't adequate, and why weren't you able to take advantage of them? And then the question for you, Sean, is why the carve out, or why do we need special funds set aside for physician practices?
Much of the early response was addressed toward Medicare patients. And for a practice like ours that focuses on pediatric and working families and has a very, very small percentage of Medicare, it was absolutely of no benefit to us whatsoever. When the PPP loan came out, that was our goal, that was our hope. And we put a lot of energy into continuing to work, believing we were going to get that government assistance. We used the bank with BBT that we had used for 15, 20 years. Sad thing is, they're a giant bank, and little did we know it, but we were at the end of the line when it came time to distribute the funds. I think only 11% of those funds went to healthcare and social services. None of these resources served us whatsoever as far as getting into our offices. I hope that addresses the question.
Yeah, I would add, this is unfortunately a scenario that we are hearing from physicians all across the country, particularly on the Paycheck Protection Program, that that money was dispersed prior to even consideration of their applications. And I am sensitive to the fact that there are small businesses all across industries in our economy that need help. But I think we need to think about the long-term impacts on health, both physical, but also mental and behavioral health, and the importance of the ambulatory primary care physician network across this country, and helping individuals maintain health, but also helping them through this crisis as we start to re-engage with our economy. I am and the Academy is appreciative of the efforts of HHS to push dollars out as they did. We think the timely release of money was important, and as Dr. Culpepper said, it didn't get to everybody in an equitable way or at all in some cases. But I think they took a reasonable, appropriate step to just try to push as much cash as they thought was appropriate at that time into the system. So now we need to go back and think of where they missed opportunities to give money and financial assistance to practices like Dr. Culpepper's and Dr. Jordan and of course Tabitha's practice in Arkansas, where they have high numbers of Medicaid patients, high numbers of the commercially insured, which aren't being supported necessarily by the private market. It is, for the average family physician, we consider they basically deal in thirds, about a third Medicare, a third Medicaid, a third commercial insurance, and that's not statistically valid. That's a generalization, but we need to think about that when we think about prioritizing money in the next tranche of funding.
Great, thank you. Another question for Dr. Westphal for the panel is, your slide made it look as though the majority of suspect COVID cases will ultimately be treated in the primary care setting. Is that correct?
So this is Jack Westfall. It is likely that the majority of people with COVID-like symptoms, that's cough, fever, shortness of breath, will contact their primary care practice first. While we've seen lots of people present to hospitals who are severely ill, it is more likely that the majority of people suffering from URI, upper respiratory symptoms, bronchitis, and even some pneumonia will contact their primary care practices, who will provide screening, testing, early treatment, and then triage to appropriate services for additional care if that's required. So yes, it's estimated that the majority of patients with COVID-like symptoms will contact their primary care provider first.
Great, thanks. Would anyone else like to add on to that? If not, we have another question talking about the Medicare Advanced Payment Program. Although this person noticed, as Sean does, that program has been canceled for Part B providers. It says, how can we work in a multi-payer solution to get advanced funding to our practices? So Elizabeth and Sean.
Yeah, I would look to Elizabeth on the private side. I think she articulated a vision really well moving forward. But as we included in the slide, we would strongly advocate that Congress direct CMS to re-engage on a voluntary basis the Advanced and Accelerated Payment Program, at least through 2020. We probably need closer to 6 quarters, but it would be great if we could just do it for the next 2 quarters of this year. I think that program and the ability to get cash flow into practices is reasonable. There are downside impacts of that because of the money has to be repaid, and there's, I know, been concerns about the interest rates and the repayment time period, and Congress could address both of those issues in legislation. But I think it is the fastest way of, when accompanied with the direct payments from the provider fund, to help practices today.
It's Elizabeth. I would only add that states sometimes also need more flexibility from CMS to design these new models for payment. And we are eager to partner with them and really encourage the commercial health plans to help implement this work. But we are aligned on the need for multi-payer reform, and we'll be bringing our members to that table.
Great, thank you all. I think we're just about at time, but I just want to call your attention to myself, Sean Grimminger, and Kristen McGovern. Our contact information is up on the slide here. If you have additional questions, follow up, if you'd like any of these resources, please email us and we will push that out to you. We will be making the slides and the recording of this webinar available. And thank you all for your time.